All right. Any question on these?
Can you go to the top, please?
Could you show me the last one, please?
All right. Okay, starting with the patella. All right. So the patella is a sesamoid bone, and at one point, during the toddler years, the common tendon of the quadriceps femoris muscles. That's the collective name for the four muscles there. So there'll be the rectus femoris, vastus medialis, vastus lateralis, vastus intermedius. So those four muscles, when they get to here, they would have a common tendon. They would come past the knee joint, and then they would articulate right at that point of the tibia. And that item on the tibia is the tuberosity. So that's the tibiotuberosity. Okay. And this is the one you can readily palpate. So it's right there. And that is the reason why with the toddlers, when they fall down and land on their knees, nothing gets nothing get bruised right here. And that's because it's just a muscle tendon right there at a time. So at the same time, if you palpate the knee of a toddler, you're not going to feel the patella there. And then as they reached the teenage years, that's when the bone would start forming there. Once it's completed, then because now this portion that is attached to the tibiotuberosity, because it's connecting bone to bone, that item now would be referred to as patellar ligament. And the item above it, somewhere up here, would still be the common tendon of the quadriceps femoris muscles. So now, when you are looking at the patella, the distal end of this bone is where it would have the apex. Apex is the distal end of this bone. And then the proximal end of it, where you have that straight border, this part is going to be referred as the base. Get to know that term, okay? When we get to the muscular system, you're going to be exposed to that term quite a bit. When a muscle is attached to something that is referred to as the base of a bone, talking about the proximal end of that bone. Okay, so keep that in mind. And the way I get the students to figure out where they are handling a right or a left patella is to simply set the patella on the table with the apex pointing away, straight ahead, pointing straight away from them. And when So here's the apex and here's the base. When it is resting on the left side, that's a left patella. And if it's resting on the right side, then it'll be a right patella. So that one's the left. Okay. And the reason for that is doesn't look right. The part of the patella that is going to be articulating with the lateral epicondyle, lateral condyle of the femur would be much wider. So what it would be resting on is actually the facet for the lateral condyle of the femur. This isn't done right here. Whoever set those pointers up is wrong. So that's the reason for that. That's the reason it's going to be resting on the lateral facet for the lateral condyle of the femur. And reason for that has to do with three of those muscles, the quadriceps femoris muscles, three of them have their tendons a little bit more lateral. And that means three of those muscles largely would be handling that patella somewhat lateral. And then vastus medialis muscle needs to be the muscle that would constantly be resisting the pull of those three lateral muscles. And that's the reason when those people that have problems with the patella dislocating always slides lateral. All right. After that, we go looking at the tibia. So again, when you identify the tibia, make certain you spelled it correctly. Make the T look like a T, okay? And first thing I tell them to do is to pick up, when they pick up the tibia, tell them to find the tibial tuberosity that's near the proximal part of the bone, and it's always anterior. Then the next item I want them to find would be at the distal end. At the distal end, this item, medial malleolus. medial malleolus. Talking about this item here. So if you reach down and palpate the medial side of your ankle, that item you feel there is the medial malleolus of your tibia. Okay, that's what you're sensing. So once they figure that, then they can tell whether they're holding a right or a left bone. Okay. This is anterior, this is medial. That's a right. Okay. And this one is a left. Okay. Then we'll go from the top down. And the very top, this item at the very top of this bone would be the intercondylar eminence. The intercondylar eminence is for the attachment of items coming from the two menisci. Okay. And then tibial tuberosity, which is on the anterior side. And then find the medial and lateral condyles. Medial condyle is going to be in line with the medial malleolus. Okay. And then for the lateral condyle, first thing I need them to look for is the fibular articular facet. So this item is the fibular articular facet. If the bone isn't chipped, then this item would be about the about the size of a nickel. Okay. So the head of the fibula is going to be articulating there. That's why when you're looking at these cadavers, the skeletons, yeah, that's where the fibula would be articulating. Now, the anterior border, it's the part that's going to be continuing down from the tibial tuberosity. And then on the medial side of the bone, right here, this is a left. So on the medial side of the bone, this would be where you would have only the skin sitting on top of the bone. You have no muscles on that side. Okay. So eventually we are talking about the anterior muscle compartment of the leg, then we are largely talking about the muscles that would be on the lateral side of the tibia. Then the next item would be coming back to the underside of the lateral condyle, where you have the fibular articular facet. That's when I ask students to find the soleal line. This is the soleal line. Soleal line is the one that is going to be traveling from lateral, somewhat diagonally over to the medial side, and yeah, so that's the soleal line. Okay. The soleus muscle is the one that is going to be taking that as its origin. And when we get to the muscular system, you'll be hearing that the soleus is a postural muscle. These are muscles that can maintain a particular position for a long time. So when you're standing for a long time, soleus muscle is the one that is going to be contracting. So when you see something like this, that has to do with this person probably did quite a bit of standing or just walking. Okay. Walking long distance, a little bit hiking. Okay. So yeah, the long runners, long distance runners are the ones that would be mostly using the soleus muscle. The fast runners are the ones that would be using the gastrocnemius muscles. So soleal line. Then after that, come back to the fibular articular facet again and follow this part, the lateral side of it, going down. And that is the border of the interosseous membrane. Okay. So interosseous border. Then after that, continue on that all the way down. You get to this part here. And that would be the fibular notch. And that's because the distal end of the fibula would be articulating right there. So let's see. Is there any? Doesn't show up very well, but it would be right there. Okay.
Professor,
Yeah.
quick question, kind of off topic. Where would the anterior tibiotalar joint be?
Anterior tibial what?
Tibiotalar joint. It's not really on the list. I'm just kind of curious, just personal.
Spell that word.
Tibiotalar.
Good. It's where the tibia articulating with the talus. Right there. That's the talus. Yeah, it's gonna be right there.
Thank you.
So now, the inferior articular surface, most books don't bother showing that because they have to take that picture. And talking about this. This is the inferior articular surface. And this is the main part of your ankle joint. Okay, it's the main part where you'll be sending your body weight down to your ankle. Now, yeah. And yeah, the ankle joint mostly is going to be referred to as a synovial hinge joint. Okay. Then the next item would be the fibula. And again, spell it correctly, make the F look like an F. So first thing I ask people to do when they pick up a fibula is to go to the distal end of the bone. The distal end of the bone is shaped kind of like the the spade. Okay. And that is the lateral malleolus. So if you reach down and palpate the lateral side of your ankle, that's what you're touching. Lateral malleolus of the fibula. Okay. Then the next thing I need them to do is to figure out whether this is left or right. So now they need to look at the medial side of that lateral malleolus. On the medial side, that's what you see. And I need them to look for that item that is referred as the malleolar fossa, talking about this one. And that has to do with on the lateral side of your leg, you have a couple of muscles with origins on the fibula, and their tendons would be coming around the back and to the lateral portion of the foot at this point. One of them is going to go down the bottom and go across to the other side of your foot, on the underside of the foot, going across like that. And one is going to continue straight to the fifth metatarsal. And again, bones form around soft material. So that is the reason you have something like this. Those two muscle tendons would have gone something like this. In other words, on this side, on the medial side of that lateral malleolus, this flat, smooth portion is the one that's going to be articulating with the talus. This is the malleolar fossa, where you have those two muscle tendons coming like this. That means this item, in addition to being on the medial side of the lateral malleolus, is also posterior. Okay, medial and posterior. So when I have the students turn this and looking at it and simply just either put a finger or a thumb right here, if the finger or thumb is pointing left, it's a left. Pointing right, it's a right. So this one is a left. Okay. And then on the proximal end, there's the articular facet that articulates with the fibular articular facet on the tibia. So, yeah, get used to that. Okay. Facet is on the proximal side, and the notch is at the distal end of the tibia. Right. So that's how these two bones would look like. Okay. And yeah, you need those two condyles to keep the foot from moving medial and medial or lateral. Okay.
Professor, for the fibula, where's that? Where's the articular facet again?
Articular facet is on the very top of the head.
Oh, the top of it. Okay.
It's like the
Okay. Gotcha. Thank you.
right. All right. Tarsus is ankle, and there would be 7 tarsal bones. And the best way to deal with where those tarsal bones are is to go back to those arches, okay, the foot arches. So is the right, or these 3 images here. So and then these 3 photos. These 3 photos are the same foot. So if we start with the medial longitudinal arch, then has the calcaneus. On top of the calcaneus, you have the talus. So calcaneus here, talus there. Okay. And then in front of the talus, you have the navicular, that one, navicular. And then in front of the navicular, you have the 3 cuneiforms. This was the medial cuneiform. So medial cuneiform, then you have the intermediate cuneiform, lateral cuneiform. So it's a navicular, medial cuneiform, intermediate, and lateral. Okay. So medial cuneiform is in line with metatarsal 1. Intermediate is in line with met 2. Lateral is in line with met 3. So that's the those are the setup bones for the medial longitudinal arch. Then for the lateral longitudinal arch, calcaneus. In front of the calcaneus, you have cuboid. In front of the cuboid, you have metatarsal 4 and 5. So that's a lateral longitudinal arch. And then the transverse arch, navicular, medial cuneiform, intermediate cuneiform, lateral cuneiform, cuboid. Those 5 bones, the transverse arch. And for the transverse arch, navicular is the highest, that's the keystone. For the medial longitudinal arch, talus is the highest, that's a keystone. Lateral longitudinal arch, cuboid is the highest. That's a keystone. Okay. So at the first MTP joint, metatarsal phalangeal joint. This metatarsal 1 is the proximal phalanx 1. At that joint, you have the 2 sesame bones there. Okay. Sesamoid bone. Okay. Yeah, so that takes care of all these. So any questions? Right, then I'll start with a quick most likely I may be able to get to most of the integumentary system. Okay, integumentary system is in your second lecture exam. Okay, so major functions of this, it's said to give you protection from external injury. So the first line of defense against the ultraviolet radiation, as well as pathogens. Pathogens are disease-causing agents. Maintenance of water balance. If the skin is peeled away, very quickly, a person is going to start losing water. Okay. And it's also there to maintain your thermal regulation. It has to do with when your core temperature is high, then all the blood vessels near the superficial part of your body, meaning all the blood vessels under your skin, would be filled. They open up and they will be filled with blood circulation. and you would constantly be sending as much blood as possible to the underside of the skin. And at the same time, you would be sweating. And once the sweat comes to the surface, the temperature there is going to evaporate the sweat. It's what we refer to as evaporative cooling. That is a hyper cooling system your body gives you. So as the sweat is evaporating, it's going to be drawing away much of the temperature. And then, of course, the blood that is there is now returning to the heart. So it's going to be bypassing all the other arteries that is still sending the blood to this superficial part of the body. So you have countercurrent blood that's flowing next to the blood vessels, flowing in the blood vessels are next to one another. So that would further cool the blood that is coming to the skin. Okay, so that's how thermoregulation is done. And that's also the reason why at that time you would look red. Okay. And if the ambient temperature is low, then you would be collapsing most of the capillaries at the skin and diverting as much of blood flow in your body core to maintain your body core temperature. And that's when you look pale. So that's how thermoregulation works. Okay. Vitamin D's synthesis is also at the skin. When you have ultraviolet light entering, and that is the actual vitamin that you need to work with at least 2 other hormones in your body to get your small intestine to absorb calcium. Communication with your skin, turning pale or what's the term for that color when someone is shy?
Blushing.
Thanks. Yeah, when you're blushing, then yeah, the that's communicating with your skin. Okay. Sensory reception. This is a set of the general senses. touch, pressure, temperature, and pain. And it's also there for excretion. When you sweat, items that's going to be sending out, mostly water, but it would also include salt and urea. Okay. Your skin takes over excretion during exercise. Okay. So that's the reason you can figure that those marathon runners, they never need to go to the urinals, okay? Even when they drink as much water as they can every time they pass those water stations, they continue running. So during that type of exercise, the blood circulation is going to be diverted mostly towards the skeletal muscles. And it's going to be kept from sending into the kidneys as well as your digestive system. So
Couple of questions, Professor.
Yeah.
What are the two hormones that are regulated with vitamin D? And also, when you're talking about excretion, in terms of working out, why is it sort of like if you work out a lot, it seems like your sweat kind of just can be very light and just kind of run off of you. But if you haven't worked out in a long time, why does it feel kind of slimier? Is that because of like built up toxins in your body?
yeah, for people who do not exercise much, anything that has taken in by cells in the body are going to be kept there, and only the new items entering are the ones going to be sent out, because cells in the body already has all these things filled. And that's also the reason why I would always suggest people to exercise before eating. And that's because your body is very much like your bank account. Okay. The original money you put in there is going to just stay there. And then all the current deposits, and when you withdraw, that's the money that's going to be coming back out. So now
Professor, what's urea?
nitrogen waste, mostly that's what's to be sent out by the cells, as in ammonia.
And ammonia. Thank you.
calcitonin is one of those hormones. Calcitrol from the kidney. Okay. So you need your vitamin D to work with calcitrol. Yeah. Calcitrol is the active hormone, and it works together with vitamin D. And that's the one that's going to be producing the absorption of calcium and phosphates in your small intestines. At the same time, it would decrease calcium excretion at the kidneys. That means whatever you sent there is going to be recycled. And it also work together with the parathyroid hormone. That's the one that would maintain homeostasis of the bones. Just a few features of your skin. On average, the skin is about 6 pounds, and it can cover about 20 square feet. Every square centimeter of skin would have 70 centimeters of blood vessels, mostly capillaries. It would have 55 centimeters of nerves in there, 100 sweat glands, 15 oil glands, 230 sensory receptors, 500,000 cells constantly dying and being replaced in just every square centimeter. So that's why even if you close all your windows and doors and totally set them so they would be blocking anything coming through, you still need to handle all those dead cells that would be in every room. So dust rabbits were always building up in your house. The skin on your fingers and toes would get wrinkled when you soak them in water. And that has to do with the water is now entering into most of the dead cells on the surface of your skins. And now they expand. So that's the reason you get get them to wrinkle. Now, yeah, the skin will also buckle into those wrinkles. Okay. Now, when you start looking through sets of labels here, making certain that you fully understand you only have these two major items, epidermis and dermis. Those are the two major parts of skin. Okay. Integumentary system is just that, epidermis and dermis. Hypodermis is not part of your integumentary system. Okay. So epidermis, largely we are just dealing with the stratified squamous epithelial cells. And then we get down to the dermis layer. Here you're dealing with the dense irregular connective tissue here. And then you also have these two sets of layers in the dermis. The papillary layer has to do with all these items here that are referred to as dermopapillae. Dermopapillae because they all shaped like nipple. Okay. So papilla is Latin for nipple. So the whole series of these right here. And then reticular layer is the part where you have your dense irregular connective tissues. But as you are looking at where these things are marked and labeled, also understand that you're going to have material up in the epidermis that push their way down into the dermis. So the hair follicles has to do with those stratified squamous cells during embryonic development had internalized, invaginate in here. And once they are in here, they differentiate into doing other things. So they would be forming the sebaceous gland cells and now fully understand that only those parts of your body where you have hair would have oil coming up to your skin. The parts of your body that has no hair, there'll be no oil. Sebaceous glands would be constantly associated with hair follicles. So don't expect oil on your palm or your foot. There are only sweat glands there. Okay. Every hair follicle would have smooth muscle attached to it, and that's the erector pili muscle. Okay. The hypodermis is essentially your superficial fascia. So in other words, right here is where you have your areolar connective tissue. And then as we continue with many of the structures in here, at every one of these papillae, you would have some sensory items there that would be referred as tactile corpuscles. Okay. And then the ones that are way down here, the deepest ones that are referred to as the lamellar corpuscle, used to be called Pacinian corpuscle. Those are the ones that is for sensing pressure. Okay. And back around the 1500s, the painters in Europe, southern painters are the ones that are the ones in Italy, and the northern painters are the ones that will be doing these types of paintings. So what the northern painters would do is they like to paint ancient events, but at that time, some of them do not care so much about figuring out the type of clothing that the ancient people would have. So they just use their contemporary clothing here. What this painting is about has to do with a something that happened in ancient Greece, and Cambyses was a judge, and he was caught accepting bribes. So he was executed. By having the skin taken out. So, and again, back in those days, as criminals, some parts of the body waste would be thrown on the ground, and that the animals here do munch on those. Now, as the skin is pulling away, you're actually damaging most of the sensory corpuscles around, and all those nervous structures, once they are ripped away, he would not be actually feeling much pain here. Main thing that's happening is that fluid is losing, and that mostly what's going to be killing him. And at some point, shock can also shut down his brain. But still, the rest of this is going to continue losing fluid. And what they did to make very certain that any other following, any judges about taking bribes, they put his skin on that court, the judge seat at the court. His son eventually grew up to be a judge, and he sit there with his father's pelt on the chair. So for the skin structure, for the superficial part going in, you have the epidermis, and we'll start at the bottom part of the epidermis, continue to go up. So at the very bottom, you have basement membrane, which is not shown here. When you enlarge something to this size, you should have the basement membrane. So they didn't label that. Okay, so basement membrane is here. And then the first layer of cells there would be referred to as stratum basale. Stratum basale, you would have mostly the keratinocytes. Keratinocyte would be all these with that color. Okay. The reason they are referred to as keratinocyte is because these are cells that are continuously producing the protein keratin. And we'll go over what the keratin would be doing a little bit later. And these are the ones at the basement membrane. The shapes are actually cuboidal shape, okay? And they are the ones that are constantly mitotically divide, and the daughter cells are the ones that's going to be sending further and further away. Now, other types of cells that would be here, melanocyte. Melanocyte are the ones that would be producing melanin. Melanin is a very dark protein, okay? And melanin is the one, it's a single item here mostly, that is going to be handling your complexion. Okay. Now, the melanocytes would have a whole series of processes, and they would have channel proteins there that is going to constantly sending the melanocyte, the melanin, which is going to be in granule form, going into the cytoplasm of the melanocytes, of the keratinocytes. And those granules in here would be taken, covering their nuclei to protect themselves from ultraviolet radiation. And then there's one more item. The tactile epithelial cell used to be called Merkel cell. The tactile epithelial cell is the one that allows you to feel whatever your skin is touching. Okay. And this is the most superficial one that is going to pick up those senses. And it's going to have a connection or synapse here with the sensory nerve ending that's going to be receiving whatever chemicals this tactile cell would be sending out whenever your skin is touching something out there. And the impulses would start at that nerve ending that's going to be taking those impulses all the way to your brain. So those are the three types of cells here. So as the ones that has been pushed further away, now you have this layer that is referred to as a stratum spinosum. Stratum spinosum has to do with when this part of the skin gets stained, the melanin granules are the ones that we're picking up that stain. So that's why they call this stratum granulosum. Okay. So these are all the melanin granules that's been stained here. And then further up, you have stratum granulosum. And that's because those granules are building up to the point where stain is much darker now. So and then after this, you would have the stratum corneum. And we are looking at the some skin that is not as thick as the ones on your hand and palm, on the palm and the sole of the foot. So it's only the thick skins that would have a layer, about 6 layers of dead cells here, that would have quite a bit of lipid items in them. So they would not be very well stained. So that's the one that's referred to as the stratum lucidum. But this is a thin skin, so you don't have that. And then further up would be cells that are so far away from where you have capillaries under or attached to the basement membrane. So these are cells that are starving and dying. So they start dying, and then because more cells are continuously getting pushed up, so at some point they get pressed and material would start leaking out of them. And the material that is leaking out has to do with the keratin, as well as glycolipids. And the keratin the keratin that is leaking together out with the glycolipids is going to make all these dead tissues into a tough piece of material. And but not for a long time. You can't stay in water forever. Okay, but it will be somewhat waterproof. For minutes. But after a few hours, then water is going to be soaking up in these dead cells. Now, about complexion has to do with the genetic structure in you. For people who would have the genes that is going to set these keratinocytes to digest the melanin, then their skin would be much lighter. So that's the only difference between light skin and dark skin people. The structures of the skin are still the same. It just has to do with how much melanin these cells digested. Okay. Something else that can happen to temporarily set up your complexion has to do with the capillaries, how much blood is flowing through those capillaries. If they're not collapsed, then you would your skin would look more pink. And as I mentioned before, if you keep taking in items that would have carotene, continue drinking carrot juice, these things would turn orange. Okay. And then the dermis layer. This is where you have the papillary layer. Okay. These are the papillae. And this is where you have, well, this part is the epidermis. And this is where you have the living cells of the epidermis. And these are all dead cells up here. And within each one of these papillae, you would have that tactile corpuscle. Okay, it's a much larger item to pick up sensation that is working on your skin. This one is also there to pick up sense of touch. Now, and once you go deeper than the papillary layer, that's a reticular layer, and that's a main layer for the dense irregular connective tissue. So this is where you would have all these collagen fibers going in different directions. Okay. So some of the landmark on the skin surface. The friction ridges has to do with the arrangement of the papillae under here. So, and that these lines would be where you have those papillae at the papillary layer of the dermis. Okay. And then you also have all these sets of sweat gland, the ducts of the sweat gland, the orifice of all those ducts. And that is the item that would form your fingerprint. Okay. The flexion creases. Wherever you have synovial joints, that will be synovial hinge joints, as well as the condyloid joints, the ones that allow you to flex your digits and other parts of the body, wrists, etc. You would need your skin to give you those flexion creases. And that's the only way you can totally flex these parts of your fingers, your knuckles, etc. Okay. And then away from the joints, you also need those other parts of the skin that will wrinkle whenever you start flexing. So those are the flexion lines. Okay. And then there is the lines of cleavage. Lines of cleavage has to do with the general direction of many of the fibers. And most surgeons would know this map on you. Okay. And to handle this, if a surgeon makes an incision that would be perpendicular to some of these fibers, then fibroblasts would have difficulty because to reform it, because the template is damaged. So it would take much longer for the fibroblasts to repair that, and the scar is going to be much thicker and wider. If the incision is done parallel to these lines, then repair would be quicker and the scar would be much thinner. Okay. This is what I usually show my class. So figure that all these lines are those fibers. So if you cut across, then it will be broken up like that. But if you cut them parallel, then it's not going to be as white. Okay. So that's a reason surgeons need to do that, to make certain that the patient would not have all the ugly scars. Okay. I will continue to finish the integumentary system after the exam tomorrow. And I'm going to be stopping this start closing. And most likely within an hour or two, I'll be sending back my my grade and correction on your essays. And for those of you who want to study a little bit together for the exam, then you can start forming some meetings. and use the rest of the time to do that. And I'll be sending the my corrected item back to whoever sent in the essays, and I'll let those ones to share those graded items with you. So take a few minutes to find out who had gone through those bonus items for the exam. When I showed the answer keys, find out who's done them well, and see if you can go over or study with them a little bit together. Okay, so I'll let you guys figure out, and so in about 10 minutes I'm going to be closing this Zoom meeting, so you have more time to prepare for the exam tomorrow.
Professor, I have a question.
Sure.
Is there going to be bone labeling on the lecture exam?
You will, well, the first 20 questions would be the part that you need to fill in. Oh, okay. Let's see.
But those fill in the blank ones may be like sort of like the crossword puzzles, or are those going to be specifically about kind of the lab stuff, or it's a mixed bag?
Just a little bit mixed, mostly lab. Here it is. Make sure you go over these pictures in your textbook. Okay.
Thank you.
You will see some of them, almost all of them. Definitely you would see these three. Okay. And you will be asked to identify items here. Okay. And by the time, by now you should have looked into that answer sheet, so you know that there are well over 20 questions on joints and well over 20 questions on bony material. Okay. So, yeah, I'll close in about 10 minutes.